Graft versus host disease remains, if not a major complication of allogeneic transplantation, uh, despite attempts to improve upon its treatment over the last several decades. What we have seen is there's definitely a change in how graft versus host disease is. We do know over the last couple of decades that we see much less severe acute graft versus host disease, and that has contributed to an overall improvement in the outcomes of our patients. There's a lot of things responsible for that. That includes better HLA typing of recipients and donors. That includes a better understanding for us as practitioners of who to transplant in terms of patient selection. And that includes a gradual decrease in the conditioning regimen that we've used. So overall, there's been a decrease in the severity and thankfully a decrease in the percentage of patients that die from acute graft versus host disease early on after transplant. Unfortunately, treatment paradigms have not evolved in parallel. While we have used a series of additional agents to try and improve upon the treatment of graft versus host disease and the prevention of such, it is perhaps not until recently that we've started to make some improvements. The historical treatment of graft versus host disease was rooted in systemic immunosuppression. We all felt that the underpinnings of graft versus host disease were donor cells attacking normal host tissue. And so intuitively, the treatment was to suppress the donor immune system. The drawback to that type of therapy is as additional immunosuppression is added, these patients are prone to more infections, and there likely perhaps was a decrease in the ability to battle these infections as well as battle the underlying malignancy. And so traditional immunosuppression has fallen by the wayside in recent developments for the treatment of graft versus host disease, as we're all looking towards other avenues to treat this disease. The overall incidence of acute and chronic graft versus host disease at our center hasn't really changed over the last couple of decades. What we have seen is a decrease in the severity and a change in the timelines. So historically, graft versus host disease was defined in patients that were much more homogeneous. They were all receiving myeloablative bone marrow transplants and were all younger. These days, the patients that we treat are much more heterogeneous. Many are older, many are receiving reduced intensity transplants. The majority of patients receive peripheral blood stem cell grafts instead of just bone marrow. And the regimens that we're using to prevent graft versus host disease are varied. And all of these things affect what we call the immune reconstitution after transplant, and that ultimately affects the timeline of graft versus host disease. We used to define acute and chronic graft versus host disease based on a 100-day timeline. Patients who developed GvH before 100 days were classified as acute. Patients who developed GvHD after 100 days were classified as chronic. With all of our heterogeneous practices in transplant, these timelines are now no longer accurate, and graft versus host disease is wholly defined by clinical manifestations. Nevertheless, if we accurately define graft versus host disease, the incidence hasn't really changed. At our center, acute graft versus host disease, I'll classify it as I talk to patients, in patients who I actually have to do something in terms of treatment, probably occurs in about 25 to 30% of our patients after transplant. Chronic graft versus host disease in the same way, where I actually have to do active management for, probably in about 40% of patients. The traditional risk factors for graft versus host disease have been defined in large studies. Those clinical factors include less HLA matching between donor and recipient. The intensity of the conditioning regimen certainly appears to put patients at risk for more graft versus host disease. Use of total body irradiation certainly puts patients at risk for graft versus host disease. There's evidence that older patients and older donors lead to an increased risk of graft versus host disease, and there definitely is some evidence that a female donor into a male recipient leads to more chronic graft versus host disease and possibly more acute. In many studies, the leading factor for chronic graft versus host disease is the development of acute graft versus host disease. So these are the main risk factors that we see. There are others as well that have been defined in small studies here or there, but those are the main ones.